Thank you all for coming to this session. And I'm Marina Kurian. I'm a surgeon in New York City. And I think this is going to be a very intriguing session for everyone. And, you know, many of us see patients that we're doing bariatric surgery before transplant, some of them after transplant. So you'll see a lot of the nuances in what we're doing here. First, I would like to introduce my moderators, please. Marco Buter from Switzerland, from Zurich. And then I'm not sure where you're actually from. I'm so sorry.
Roberto Troisi, transplant surgery, Frederick II University, Naples. So
in Naples.
Local.
Oh, you're home. Very good.
Thank you.
Okay, so thank you both for being here. And then we're going to introduce the first session, which is going to be the systematic review on Angelo, the first session, and he's going to introduce a systematic review on this topic.
Good morning, and thank you for this great opportunity to talk about systematic review for new ASMBS IFSO guidelines. That's my disclosure, no disclosure for this presentation. Where we start? We start from the recently published guidelines on bariatric metabolic surgery, and particularly about organ transplantation. The author for this document finds 7 articles, and include inside this recommendation joint arthroplasty, abdominal wall hernia repair, and state that bariatric metabolic surgery could be offered to patients before this kind of operation, without being very specific on transplant organ. Thanks to Maurizio De Luca and Luigi Angrisani that coordinate this group, we start to do a systematic review following the criteria of systematic review. We did a PRISMA and find all the solid organ transplant and the bariatric surgery, and find for this topic 34 articles that we analyze separately. So start with the heart, lung transplant, kidney transplant, liver transplant, and the paper that have a mixed procedure, so all the transplant and bariatric. What do we find? For heart-lung transplant, we found just 2 papers, a retrospective paper, but it's interesting to note that the advantage of the bariatric metabolic surgery before heart-lung transplant in the majority of patients, look at all the paper, the first one, 27% of patients were successfully transplanted. And interesting, close to half of those were they gained the target of BMI to be transplanted. And this paper that was cited also in the document of ASMBS of McElderry showed that the patients that have bariatric metabolic surgery before heart lung transplant have a 3-fold higher probability to be transplanted. That's very interesting. So the summary of these 2 papers, metabolic bariatric surgery improved the possibility to be transplanted. Regarding liver transplant, it's a little bit complex because some papers show concomitant bariatric surgery and liver transplant. There was just one case report with sleep. Another paper show metabolic bariatric surgery after liver transplant. The majority of papers, there are 6, show metabolic bariatric surgery and report metabolic bariatric surgery before liver transplant. At the end, what are the summary? That concomitant, there is only a case report, and it's feasible with the sleep. It's look feasible with the sleep. The auto report, no complication, no mortality. And after, have a higher cost due to longer hospitalization, a higher risk for the adhesion particularly. And before, it look like the better option. Listed patients is a range between 40 and 80%. A successfully transplanted patients still 40%. Regarding kidney, the literature is a little bit homogeneous. We report 15 papers of metabolic bariatric surgery before kidney transplant. The results are all study retrospective, with a number of patients range between 16 and 500, with a multiple bariatric procedure. The author include AGB, sleeve, gastric bypass, or IGB. The follow-up mean was 1 year. Complication range between 3 and 16%, higher of course in patients with the end-stage kidney disease. mortality till 2%. Some papers report no association between metabolic risk of death, and the listed is a much more interesting number because it's till 100%. And another specific data that comes from the study, and some patients, around 20%, have so dramatic amelioration of kidney function that doesn't need transplant anymore. And after kidney transplant, just 2 papers, the same with the mixed group. So where the author analyze data in patients that have a kidney transplant or have to do kidney transplant. The results interesting after kidney transplant are that the patients that have a bariatric after kidney transplant have a less onset of type 2 diabetes and need less therapy, particularly with statin. And the other one is the glomerular filtrate ratio is ameliorated in patients that have bariatric surgery after kidney transplant. So what are the summary of this data? Concomitant with no data, no report in bariatric and kidney transplant together. After is have lesser mortality, lesser risk of type 2 diabetes, new onset statin therapy, and before have a potentially higher mortality compared with after, but close to 100% of patients are listing for kidney transplant. They target the BMI to have a kidney transplant. Mixed procedure, that means the bariatric in different settings, just 3 papers. The results are of this retrospective study in a population range between 38 and 469, show a mortality till 10% and higher admission and ICU admission. Just final consideration, because we are doing now the meta-analysis and try to analyze it to have a recommendation on this. I don't think that we gain the power, statistic power, to have a very strong recommendation, maybe conditional or statement on this topic, because the study are all retrospective. It does exist randomized controlled trial on transplant and bariatric. So our retrospective, the surgical procedure are different, sleeve, bypass, ORGB, AGB, the disease status and nowhere reported in the study, and some specific data sometimes are missing. Operative time, weight loss, complication rate are not methodological report homogeneously. At the same time, bariatric metabolic surgery from the paper are much more used before solid organ transplant because improve the accessibility and listing, possibility to be listed for transplant. Can be performed after solid organ transplant, but sometimes significant affect complication rate and mortality. Regarding technique, from the paper is not so strong as I report in the sentence, but with bypass, particularly if you look inside the data with these retrospectives, have patients much more complication, particularly metabolic complication. So sleep seems to guarantee SRA results. It seems to be safer for these patients. In every case, of course, all the authors want a multidisciplinary, and this kind of operation should be performed in place, in hospital. They do both, so bariatric and transplant surgery. Thank you for your attention and for this opportunity.
Thank you very much for that quick overview. Thank you. Are there any questions from the audience? Maybe, yes, one quick question.
In order? Oh, no. There were no data on this topic. Yeah, thanks for the question.
Right. Maybe I got one quick question.
Yeah.
You talked about, MBS before or after SOT, but there are also some data of during it, doing it in one session together, right? Especially in terms of liver transplantation.
Yes.
Are there
was
any
just
data?
one case report.
Is that the one from California, or where they did it together?
Yeah, I will show you. It's from California, yeah.
All right. I'm just saying that also an option, right? You know,
Yeah.
because it's usually very handy to do a sleeve gastrectomy once the liver is being taken out.
Yeah, it was done by a different team. It was interesting.
Yeah.
Yeah. Okay.
So the bariatric team
Yeah,
comes in,
yeah.
and then the transplant team takes over. Thank you very much.
You're welcome. Thank you.
I can introduce it, yeah. So I introduce next speaker, who is Gerhard Prager from Austria. He will speak about, give a talk about critical management aspects of bariatric surgery in transplant patients. Please.
Dear friends, thank you for the opportunity of the floor. I think the first two talks will prepare the field for the talks that go specifically into kidney, liver, small bowel, whatever. My disclosure, my case mix slides, you see we are a university hospital with quite a big number of revision. Sleeve gastrectomy is quite small in our cohort. SADS and OEGP almost go for 50%. So I think what was already said, and I will stress that metabolic bariatric surgery, I think you have two aspects, before transplantation and after transplantation. During transplantation, I would not really make it too broad, because these are really only very, very few case reports, and I wouldn't dare to draw any conclusions from these few cases. But what is of course true, what you see throughout, when you do bariatric metabolic surgery, in these patients you have a higher morbidity. You don't see higher mortality, but you see definitely higher morbidity, and I'll go with you through that. So overall, obesity, and especially obesity class 2, class 3, we should get away from terms like morbid obesity, are relative contraindications for transplantation. And I brought you an example. For heart, it's not overall the same. In different European countries, when you have a BMI above 30, you are considered a contraindication to heart transplantation. You will not go to the heart transplant list. In other countries, it's in the US, it's BMI 35. So obesity itself is a significant challenge in the access to transplantation. So one aspect is to treat obesity before the transplantation. And keep in mind, on the other hand, obesity after transplantation has, of course, a negative impact on the outcome of transplantation, number one. And due to the immunosuppressions, people gain weight often after solid organ transplantation. This is also another important factor. So, as I said, you see several papers now, but I won't go too much into detail, not to steal the show for the speakers after me. So, addressing obesity before the transplant means to improve access, what was already said, and there are several papers on that, especially from kidney and heart left ventricular assisted device. Kidney, you see an improvement in the filtration rate, and some of these patients even don't need transplantation after they have undergone metabolic bariatric surgery. This is especially true for the LVAD, the left ventricular assisted device. We did in Vienna 7 of these patients, and this is really in line with the published literature. The most common complication after metabolic bariatric surgery in LVAD patients is, of course, bleeding complications, because you operate on fully anticoagulated patients. But you always have to balance, because in LVAD patients, the most common complications are thromboembolic complications. And these patients are often several years on the artificial heart pump. They have chronic line infections. They have arrhythmia and all these other complications. So their only chance is to get on the heart transplant list to lose weight. They know that, nevertheless, they are not able to do that. So I think metabolic surgery is a wonderful indication for these patients. And similar, of course, in the kidney transplantation. Liver is a different thing. Marco already mentioned the simultaneous operation with the sleeve gastrectomy, and maybe I will comment a little bit later on which type of operation we can do. So improve access, of course, also facilitate an easier operation. You are well aware, especially in the kidney transplantation, the higher the degree of obesity, the higher the probability of complication. Means wound infection, And of course, it's much harder in the depth to do the anastomosis, the vascular access. And we have a nice cooperation in Vienna with our transplant surgeons and nephrologists. This is maybe even more important because these patients usually come from the nephrologist. In patients with BMI, with class 3 obesity, they first undergo sleeve gastrectomy in our hospital. We would like to see the patients with class 2 obesity, but there is a kind of discussion. You know the obesity paradoxon on the chronic dialysis, and they claim that they don't want to send these patients, but that might be a different topic. So facilitate an easier operation and, of course, improve the benefits of the transplant, which means to guarantee that the transplant survival is as long as possible. About metabolic surgery after the operation, of course, as I mentioned already, not to harm the transplant, which is of course one thing, and on the other hand, to guarantee that the transplant acts as long as possible. And I already mentioned it, kidney function, there are good data on that you can preserve the filtration rate, and there are also good data, but maybe this comes later for the specific organs, that you can increase the LVEF in patients with heart failure or after transplantation also. So what are the most common operations in the literature? And of course you guessed it or you know it, it's sleeve gastrectomy mainly, followed by Roux-en-Y gastric bypass. Now you would argue hypoabsorptive procedure, immunosuppression levels, this is of course a hot topic, and you must be aware that these Roux-en-Y gastric bypasses usually are bypasses with short biliopancreatic limb. So there is a word of caution for hypoabsorptive procedures in the transplant setting, because you have of course to monitor the immunosuppression levels, and when you exclude bigger amounts of small bowels, you might see a drop in the immunosuppression levels. Saying that, there are also some papers that show that after metabolic surgery in the first few weeks you see a decrease in immunosuppression levels. So you must be aware of that, which means when you do metabolic surgery in transplanted patients, you must of course monitor very carefully the immunosuppression levels, because if you don't do that, you might harm the organ in terms of rejection. Okay, actually that's that slide. I want to summarize already. In transplant candidates, as I mentioned already, we bring more patients to the transplant list, and of course the goal also, if you do it before, to improve the organ function and facilitate the transplantation itself. We need a tight cooperation with the transplant unit, and keep in mind to be careful about decompensation. Why? Because a lot of these patients suffer from cardiovascular disease. Many are diabetic, many have plaques, atherosclerosis, and there are good data on that the cardiovascular complications in metabolic surgery in these patients is higher. But as I mentioned, higher morbidity, but not higher mortality. About post-transplant patients, as I mentioned, obesity leading to dysfunction of the transplanted organ, and you see also an increased mortality in obese patients after transplantation, and here the goal is to improve and preserve the organ function. Sleeve gastrectomy as the most commonly performed operation, also with a lower complication rate. And be aware and be careful about hypoabsorptive procedures. So what must we take care of? What are the caveats to monitor organ function, immunosuppressive levels? We don't have to be afraid, but there is a morbidity, and saying that, an outlook for the future, because there is a morbidity, I'm sure that the new anti-obesity medications will play a more important role for those patients before transplantation, to bring them down with, let's say, 15 to 20% total body weight loss, because you have no bleeding complication, of course, when you use these new drugs. Thank you very much for your attention. I want to invite you, so I skipped one slide now, how to go back, to Vienna, and of course, World Congress, Melbourne, September 2024. Thank you very much.
Question from the floor. Maybe I have one question. So from your radio, I think You are asking for bariatric surgery after transplant in most of the cases because
Yeah.
there is probably null mortality. Well, we have to anticipate some morbidity. And you gave a good example of sleeve gastrectomy before cardiac transplant. So you say that probably we could avoid a certain percentage of surgery if the patients are improving. Is there any risk that morbidity would definitely preclude transplantation if we do before access to the list some kind of bariatric surgery?
Morbidity would do what? I missed it.
I mean, some complications that will definitely make impossible a transplant.
Make it not possible?
Yeah,
You mean,
yeah.
well, if you're able to do metabolic surgery before, I think you will also be able to do the transplantation. When you look at the literature for, and bring now the example for heart transplantation, in a meta-analysis, they could show that 71% of patients were listed for transplantation, for heart transplantation, and out of this 71%, 56% were transplanted, which is, I think, really good numbers. As I mentioned, when you look at MBS QIP data, so big data, and they compared 300-something patients after transplantation and looked at the morbidity, they could see longer hospital stay, more leaks, and higher morbidity, more complication rate. So this means we must be very cautious. We should only do these operations in centers where also the transplant unit is there, and we need to monitor the immunosuppression levels.
I have also the pleasure now, thank you so much. If no other question, I will introduce Professor Geerts. Anja was my previous hepatologist when I was working in Ghent, Belgium. And she's focusing on metabolic liver disease and transplant. So Anja, thank you for coming here. And your talk will be on obesity surgery and AFLD, call for liver transplant. Please.
Thank you very much, Roberto, and the other chairmen for the opportunity to speak here today. These are my disclosures, but not related to the presentation today. The obesity epidemic has led to a dramatic rise in metabolic, in liver-associated liver disease, MAFLD. It's a new name. It stands for Metabolic Dysfunctional Associated Fatty Liver Disease, previously known as NAFLD. Here you see that MAFLD affects 1/4 of the global population, with the areas in red having a prevalence of more than 30%. Due to the rise in obesity, the indications has shifted for liver transplantation. Here you see on the right a rise in the incidence of liver transplantations for NASH-related cirrhosis, in Europe, but also in the US. And here on the left, you see HCC development on the background of liver cirrhosis is increased 11-fold during the last 15 years, and that makes that MASH is the fastest growing cause of HCC in liver transplant candidates. Weight loss is currently the cornerstone of treatment for patients with MAFLD. The magnitude of weight loss is associated with NAFLD improvement. But we all know that lifestyle modification works well, but it's hard to achieve. There is no magic pill to cure MAFLD at this moment, promising drugs in clinical trials, but no FDA approval yet. And this brings me to the topic of the potential effective treatment of bariatric surgery in patients with MAFLD. And indeed, there are positive effects. Here you see nice data of the group of Lille. They performed biopsies at the moment of bariatric surgery and then again after 1 and 5 years, and they could show a remission of NASH in more than 85% of this cohort. Next to the beneficial effects on the liver outcomes, there are also potential beneficial effects on cardiac events. And of course, recently there is a paper published in The Lancet and also yesterday presented at a conference that bariatric metabolic surgery is more effective than lifestyle interventions in patients with MEFL-D. So here, the potential indications for bariatric surgery in patients with MEFL-D. Here some indications are listed out of our recent review. So potential indications for liver transplantation can be in obese patients with NASH fibrosis to prevent the occurrence of cirrhosis and the development of HCC. You can perform bariatric surgery in selected patients with liver cirrhosis without significant portal hypertension. The recommended surgical method is here sleeve gastrectomy, and of course it's in order to prevent further decompensation. And we heard it already yet, there is a possibility to perform bariatric surgery in post-liver transplantation in order to prevent recurrence of NASH and fibrosis progression. But of course, there are also pitfalls. Liver complications after bariatric surgery are a poorly known entity, but well described for many years in several case reports. The underlying mechanisms are not well understood yet, but probably this is a combination of rapid weight loss, malnutrition, toxicity of bile acids, and bacterial overgrowth in the excluded limb. Liver complications up to 10% are described previously in old severe malabsorptive procedures such as unioileal bypass and the biliopancreatic procedures or the BPD procedures. Here you see a rapid weight loss, severe malnutrition, and due to the rapid weight loss, there is a massive decrease in adipose tissues with the release of free fatty acids reaching the liver through the portal vein, and that is the reason why you can have a liver injury. We published in 2010 one of the largest case series of liver transplantation for hepatocellular failure after bariatric surgery. 1 case after unioileal bypass and 9 cases after BPD surgery. The onset of liver failure after BPD procedure ranges from several months to several years. 2 patients died on the waiting list, and the time of BPD reversal was as soon as possible during the transplant or several weeks after the transplant. And indeed, a reversal of the bypass is necessary in severe malabsorptive procedure after a liver transplantation to prevent recurrence of steatohepatitis and to rescue, of course, the liver graft. Here you see a typical picture of an histology of liver injury after bariatric surgery. You see here on the left massive steatosis, predominantly microvesicular steatosis, and on the right an image of ductular cholestasis in the periportal zone. We call it cholangitis lenta, and this is a classical sign of malnutrition associated liver injury. Are there cases of liver failure after the classic Roux-en-Y gastric bypass? There are some cases, but when you look into detail, potentially these are high-risk patients with already previously cirrhosis, so probably the best option there was a sleeve instead of a gastric bypass. There are patients with distal versions of the gastric bypass with a higher potential of malabsorption, and there are cases again with rapid weight loss with an incidental finding at the time of surgery of a cirrhosis. And currently there are some case reports of liver failure after the one anastomosis bypass. And typically the clinical picture is again a subacute liver failure developing several months after bariatric surgery with signs of progressive jaundice, and on the biopsy the clinical picture as I already shown previously. And in some cases the surgeon managed to prevent a liver transplantation by performing a redo procedure by lengthening the common loop. Another negative impact, and at this moment the major cause of liver complications after bariatric surgery, is the alcohol abuse in these kinds of patients. There are several reports showing an increase in alcohol use disorder after bariatric surgery, predominantly starting in the 2nd year post-operatively. And it seems logical that when you have already had a first hit to the liver of obesity, and then you have a second hit of alcohol, that the liver injury will be more set in quickly than when you have only one hit. Here you see the potential mechanisms involved in alcohol use disorder after bariatric surgery. There are changes in alcohol pharmacokinetics. Patients experience a greater feeling of drunkenness. There are changing in gut hormones. All these factors influence the prefrontal cortex activity, which might contribute to an increased craving for alcohol or other substances. And we were wondering what the impact was of alcohol on alcoholic liver disease in this patients group. We performed a retrospective monocentric trial in patients listed for liver transplantation for the reason of alcoholic liver disease between 2008 and 2018. And you see here we had a prevalence of a previous bariatric surgery in 6%. And on the right, you see the characteristics of the patients. In the patients with the previous bariatric surgery, you see predominantly female patients, and the patients were also younger at the time they were listed for liver transplantation. And the most important message is the severity of liver disease. Patients with a previous bariatric surgery and afterwards alcohol abuse had a more severe liver dysfunction compared to the non-surgical group, as seen here in the lab values: a lower albumin, a higher bilirubin, a higher MELD score, and also the time between diagnosis and listing was less. We are now confirming these results in a multi-centric trial, and we see again the same characteristics: female patients, young patients, the time spent on the waiting list for a liver is lower. And when you look to the complications, wherefore the patients need to be transplanted, you see again the clinical picture of severe liver dysfunction with complications such as ascites and infections, and less HCC development as a reason for liver transplantation. And of course, an important message here: there is a higher alcohol relapse in the patients with the previous bariatric surgery, so we need to pay attention for the alcohol abuse after liver transplantation. And here are data presented by our PhD student Louis Ongena yesterday here at the conference about patients hospitalized with alcohol-related liver disease and prior bariatric surgery. I will not go into detail because it was already presented yesterday, but I will show you the key messages. This is a cohort from 2018 until 2022, and we already see an increase of patients with a previous bariatric surgery, 14% compared to 6% in our old cohort. The cause of death here is an acute on chronic liver failure. Again, also, and as in our previous reports, patients who are younger
do you mind to come to an end, please?
And a severe liver dysfunction. I'm almost there. The outcome of liver transplant in patients with prior bariatric surgery, just a small comment: the outcomes are comparable, but there is a paper that showing higher rates of delisting or death after liver transplantation, and this is due to malnutrition and sarcopenia in patients with a previous bariatric surgery. So, Mr. Chairman, in general conclusions, there are benefits of bariatric surgery in MFLD patients, but there are several pitfalls: severe liver failure due to malabsorptive procedures, importance to recognize the subacute liver failure in order to avoid liver transplantation by adequate nutritional support and bariatric surgery reversal, and of course, major cause of alcohol use after bariatric surgery with a potential indication for need to liver transplantation. I thank you for your attention.
All right, one quick question because we're already behind in time pretty much, please.
Francesco Papadia from Genoa, Italy. Do you have any comment about the different kind of liver failures after bariatric surgery? Because my impression is that early liver failure is different from the liver failure that we encounter many years after the operation. Because in the first case, malnutrition seems to be very prominent, whereas I have seen cases many years after bariatric surgery that do not really seem malnourished. Nonetheless, they show a cirrhotic liver.
Yeah, indeed, there are two types of liver failure after bariatric surgery. And when you have a more severe malnutrition, with more severe malabsorptive procedures, we see such a kind of subacute liver failure. In other patients with less malnutrition, so better nutritional support after bariatric surgery, they develop later on can develop later on to a cirrhosis, but probably this is due to concomitant factors like alcohol. Indeed.
Thank you very much.
Thank you.
So I would like to welcome the next speaker and presenter. It's Ms. Corrigan McBride Aguilar from the US, talking about heart and lung transplantation bariatric surgery. Thank you very much.
Thank you very much to the moderators and the program committee for the opportunity to talk. Like all of you, I come from a transplant center that does hearts, lungs, kidneys, livers, pancreas, small bowel, and I have a great collaboration with my transplant colleagues. None of my disclosures are pertinent. But what I was assigned today was to discuss the use of bariatric surgery in heart and cardiac transplant, as well as the pulmonary and lung. And as has already been described by some of the previous speakers, there is some literature about this pre-op. There is only case reports of doing simultaneous, as well as post-operatively. So I'll try to stay on time. As already mentioned, we have our new ASMBS IFSO criteria, and I think they very nicely outline how we can assist in getting patients ready for transplantation, and it is safe and effective in all of these populations. We all love what we do as bariatric surgeons, just to see patients do well. But when patients get hearts, lungs, kidneys, this is actually a patient who was actually able to avoid a lung transplant. And by the way, I have permission of all of these patients to share their pictures and their stories, as well as patients that sometimes can get their LVADs decannulated and don't need heart transplant. It really sends up a call and a cheer in the clinic about how wonderful this is. As far as heart failure and heart transplant and LVAD patients, this is actually the first case report that I was able to find that started our program down the idea. They started with only 6 patients, 3 of them had LVADs, but there was no question that with the weight loss, the LVAD patients did have longer OR times, EBL, and length of stay, but the excess body weight loss was significant and was similar to other populations, and all of the 6 of the patients became transplant eligible. This started the conversations at my organization about what was possible. But most recently, there was this meta-analysis about bariatric surgery and LVAD devices that I think really validates what we're all doing. In looking at 11 different publications, they found 271 patients, the majority of which did have vertical sleeve gastrectomies, but there were a few laparoscopic Roux-en-Ys. The majority of the the numbers in parentheses are the number of studies that actually reported on a specific data point. So 6 studies did report on the cause of the heart failure, and by far non-ischemic cardiomyopathy seems to be the indication. Of the 5 studies that reported operative time, they were slightly longer operative times than most of our mean. And as other speakers have mentioned, the length of stay is significant. These patients have to be fully anticoagulated on warfarin or Coumadin, and that takes time to get them to a place where they are therapeutic but not super therapeutic, because I also find, as many of you probably have, our diet is very low in vitamin K, and so it's very easy to overshoot with the warfarin. We've had many patients that we actually overshot, and then they end up staying in the hospital for several days, waiting for things to come back down. Many of these, oops, I'm sorry, what just happened there? Many of these patients, probably based on center criteria more than anything else, did have ICU stays. The 30-day readmission rate for this cohort is also higher. Again, in my experience, it is mostly related to bleeding, but we have had a few LVAD failures from thrombosis in the first 30 days, as is reported in the literature. But the transplant-free mortality is about 10%. Of the patients that had have significant complications reported in this meta-analysis, the majority were major adverse cardiac events, but GI bleeding and LVAD pump thrombosis have also been pooled. But most importantly, when we think about the earlier speaker who talked about what the criteria is, 63% of the patients could reach a BMI under 35, which made them eligible by most US centers. And as a result, they've been successfully listed for transplant. And as of the publication of the studies that fed the meta-analysis, 32% of them had been successfully transplanted. And it takes about 13 months to get to transplant. As far as a few little tips, and I did try to put this in quickly, if you've never done one of these, the drive line is not supposed to run through the abdomen, but it often does, and then the result is you get adhesions. The other thing I wanted to point out, if you've never done one of these, the short gastrics tend to be much bigger than we would expect, very similar actually to our pre-liver patients, probably because of the right heart failure. The pressures also can be higher, and so if one of these short gastrics does start to bleed, it can be challenging. I like to tell the fellows and residents to double burn it so that there's almost a little cuff you can put a clip on. Just like livers, or cirrhotics or NASH patients, the liver can be very challenging to hold up out of the way because the drive line is in the way. You can see here, I've actually got the fan retractor getting ready to go in. For these patients, I do find it's easier to put the fan in from the right lower quadrant because you can't use something like a Nathanson usually because of the drive line. Now, sorry, somehow I keep going backwards. We'll go through this. Now, there has been one very small published case series of doing LVAD placement at the same time as sleeve. Every time I read this study, I get a little sick to my stomach thinking about it, but there are certainly people who are doing it. Basically, the LVAD was put in through a median sternotomy, and they did a sleeve using 4 ports. As others have talked about, though, all 4 of these patients either had complications or very long length of stay. None of them were related to the sleeve. They were all related to the LVAD, but they are, it is something to think about if you're going to venture into this. Our own data, this is actually about a year or so old, but we had 11 patients with LVADs. You can see their demographics here. Much like the national data, most of our patients are non-ischemic cardiomyopathy. And I think the important thing is we tracked their NYHA classification, and essentially these patients that are in these higher 2s and 3s and even 4s, their heart failure is improving. We have had 6 successfully bridged to transplant, 2 that were decannulated to improve function. I would be interested to hear others' thoughts. What was interesting to me is both the ones that we were able to decannulate were young women who had postpartum cardiomyopathy. So they seem to have a better reserve than the other patients. 2 are actively listed, and some are still losing weight. And you can see the listing here. As far as complications, we've had 1 case of gangrenous cholecystitis at 36 days, as well as a gastropathy years after transplant. As far as the lungs go, the major issue, and this is the same center out of the Brigham, patients with GERD have a worse lung transplant allograft survival, both early and late. So I think the moral of the story when you read the literature is we do not want to be doing anything that will increase their risk of reflux. Now, bariatric surgery has been reported in patients with interstitial lung disease. This study had 25 patients. Again, they did, and unlike almost every other transplant we do, more bypasses than sleeves, and 7 of them were potential transplant candidates if they lost weight. At the time of the study, they had only transplanted 1 patient. The real issue here is these patients absolutely have more complications in the gastric bypass cohort than the sleeve cohort, but since the number 1 reason why patients are unable to get a lung transplant after obesity is GERD and the risk of microaspiration, most of us would say we should not be doing a reflux-causing operation. So in conclusion, I think bariatric surgery is safe and effective and certainly has long-term sustainable results. There are significant improvements in cardiac and pulmonary function after bariatric surgery in all of our patients, but it can be effectively used as an adjunct to get people to transplantation. But it is not for the faint of heart, and I think it's certainly, I work in a transplant center, and I appreciate having the help of my nephrologists, my hepatologists, my CHF cardiologists in caring for them, because they absolutely can have complications. And again, I would reiterate, if you're thinking about lung transplant, it's really probably better to do a bypass because of the risk of reflux. Thank you, and maybe I caught us back up. I didn't have the time going. I had no idea.
Well, thank you very much also for keeping the time. That was great.
Oh.
Can I ask one?
Absolutely, absolutely.
I like the point with the reflux and sleeve gastrectomy in the lung transplant patients, but these patients are also very complex if it comes to immunosuppression. They often have like 3 or 4. So do you have any data on pharmacokinetics after Roux-en-Y in these lung transplant patients?
No,
Is that a problem or is that not a problem?
No, I mean, I've had this conversation with our lung transplant doctors, and in talking to the pharmacologists, we were really unable to find any data. But in evaluating it, they felt like everything that they typically need to use, they have levels and they can check, and so they simply do more frequent surveillance early on to do the micro adjustment of the dosing. We had a similar conversation with our kidney transplant because I think they had similar concerns. And really at the end of the day, what they feel like is they can keep ahead of it with monitoring levels.
Yeah, that's what I think too. I think the issue of limited pharmacokinetics after bypass is overrated. I think most often it turns out to be not a problem.
Well, thank you very much.
One more question from the floor. Can you go to the microphone, please, and will be better for us.
More of a comment with most of the immunosuppressive regimens out there now, Prograf, Cellcept, and steroid. The Cellcept can still be given IV during your postoperative period, and the Prograf actually has very good sublingual absorption. You can actually half the dose of your sublingual to meet the total requirements, and they get excellent Prograf levels very consistently.
Thank you, we appreciate that.
Okay, thank you very much. So next speaker will be Nestor de la Cruz Munoz from USA, who will give a talk on bariatric surgery considerations in renal transplant. Please.
Great, good morning. And thank you very much for the opportunity to speak. Let's get started. Here are my disclosures. None have any direct association with the talk today. Okay, so the first topic really is, how do patients with obesity do with end-stage renal disease, and that's kind of been covered this morning. I wanted to mention, the obesity paradox has already been brought up, and I'm not going to go into it. But then, if we look at a French nationwide renal epidemiology and information network, they looked at 19,524 patients from 2002 to 2011. And what they found out was that if their BMI was higher, they had less chance of transplant. And BMI above 31 was associated with a lower likelihood to get a transplant. And it was interesting because if the patients lost weight, their chances of getting a transplant increased incrementally for each drop in BMI points. So a lot of what the previous speakers have been saying shown true here, in France as well, not just in the United States. And then Nicoletto did a meta-analysis. And interesting, kind of different from what I've always been taught or thought, was that they showed that before the year 2000, obesity was a risk factor for graft loss and cardiovascular death and all-case mortality. But then after 2000, the survival rates and everything was pretty much the same. I know if I speak to my transplant team, they don't feel that this is the case, but this was what these guys found in their meta-analysis a few years ago. So questions that I'd like to answer is, can bariatric surgery be done well in end-stage renal disease patients? Can it be done well or safely in renal transplant patients? Which operation is best for them? And what to do with peritoneal dialysis patients, which is always a question that kind of comes up. So looking at the first question about metabolic surgery in end-stage renal disease patients, kind of discussed already. We have some new data looking, this was published in Annals of Surgery last year. It's a retrospective cohort study investigating association between surgery and the risk of mortality for at least 5 years post-surgery. And they were trying to see if the association was modified by the incident development of end-stage renal disease or not. And this was obesity class stage 2 and 3 and pre-dialysis renal patients. So it was 102 patients that they followed, compared them to non-operated controls, and they found a 79% decrease in mortality. And it was unrelated to whether they developed end-stage renal disease during that time period or not. So showing that really makes a significant difference mortality-wise. In a meta-analysis published in SWORD just last month, there was not a lot of great studies that they included, but they actually did 2 meta-analyses within this article. The first one was looking at bariatric surgery with patients and without patients with and without end-stage renal disease. They looked at 6 separate studies, and then gastric bypass versus sleeve in patients with renal failure. So trying to choose the procedure, and they saw 8 studies. The problem was they said that the risk of bias was moderate to serious in all the studies, and that the studies were low in number in terms of the number of patients. So what they found was a higher post-op complication rate with an overall risk of about 2.82. Oh, there we go. Higher rates of reoperations, higher rates of readmissions, and higher mortality rates, even 4 times the mortality. I think, this looks nice and scary, but as you're going to see in the data that's coming up, we're kind of victims of our own success because a 2 to 4 time increase in complication rates and mortality still is pretty low numbers. And we'll see that when we look at real numbers in a second. And then in their second meta-analysis looking at sleeve versus bypass, they showed about 10% lower complication rates in their sleeve patients over their bypass patients. And so their recommendation was sleeve for this complicated group of patients. Okay. Then in an article that just came out in Surgical Endoscopy this year, it was using the MBSA-equipped database from 2015 to 2019, over 700,000 patients overall. 5,800 patients with kidney disease and 2,266 patients on dialysis. So a large cohort of patients. They were 74% were bypasses and 25% were sleeves. So it looks like the surgeons of the country have spoken in their procedure choice. But that kind of mirrors what's going on around the country anyway for overall procedure choice. And consistent with the previous study, they found that the chronic kidney disease group had higher complication rates, perioperative complication rates, readmission rates, reoperation rates, reintervention, and if you'll see here, a 3-time increase in mortality. But that 3-time increase in mortality was still a 0.06% mortality rate overall. So still very acceptable. And what they said was, the risk is still considerably low, and the potential benefit of renal function improvement and candidacy for renal transplantation outweighs the risk, and so they should be considered surgical candidates. And it is making a significant improvement in getting them on transplant lists. So can it be done safely in renal transplant patients? I think I didn't find as much data as I would have liked to have, but there was a paper, a review study in the World Journal of Experimental Medicine last year that looked at seven studies. They were all pretty small, total about 60 or 70 cases. It was pretty weak evidence. There we go. And overall, it showed that regardless of the type of procedure, whether it was sleeve or bypass, and regardless of how it was done, whether robotic or laparoscopically, the significant weight loss and improvement in related conditions really were worth doing the surgery with a trivial mortality rate in a high-risk population. So, like I said, the overall evidence was pretty weak. Their conclusions, you can make with it as you want, but we'll talk about a couple of others. There was one in SWORD published earlier this year that was looking at bariatric surgery before and after kidney transplantation. And This was, they did 22 patients that underwent kidney transplant first, 34 patients that underwent metabolic surgery first, and then they looked at the cohorts, and they concluded that both pre- and post-transplant metabolic surgery were safe and effective, and they didn't have any significant difference in 1-year weight loss, 1-year percentage of excess weight loss, and the incidence of post-op complications. But I have to question if there was just too small a sample size, because the numbers seemed a little bit different. Even though the sample size was smaller, the kidney transplant patients had a better excess weight loss with the kidney transplant patients first at 75% versus 57.9% for the patients that had bariatric surgery first. And the percent complication rates were 50% for the patients that had bariatric surgery first and 36% for the ones that had kidney transplant first. So I don't know how well they controlled for the length of obesity, if they looked at if the kidney transplant patients were patients that developed obesity after their transplant only and maybe weren't as sick as the ones from before. But I suspect that given enough patients, we might see a difference between those two groups at some point. And probably in this case, at least, looking that kidney transplant first might be better for this. So I thought that was an interesting thing, different from what we've seen. And then this 2-year metabolic health outcomes in patients undergoing bariatric surgery after renal and kidney transplant. This was presented at a major GI conference earlier this year, and they looked at patients with, it was a retrospective multi-institutional study, and they had 61 kidney transplant patients who underwent bariatric surgery and compared them to 24,000 kidney transplant patients matched to BMI. And what they found was that the overall mortality was significantly reduced in the bariatric surgery patients at up to 2 years after surgery. And there was a decrease in glomerular filtration rate at the different times, and a significant decrease in AKI, as well as a decrease in sleep apnea. So which operation is better for them? I'm going to go through this quickly because I'm running out of time, but that same 5-year SWORD database paper showed that gastric bypasses had an increased rate of deep space organ infection and reinterventions, over twice as many, so they felt that sleeve was a procedure of choice. The SAGES manual says they feel sleeve is the procedure of choice, although it was pretty much based on opinion. And looking at our data, we had 31 patients with end-stage renal disease that we did gastric bypasses in. 87% achieved a BMI less than 35 after surgery, and of them, 14 were transplanted, and compared to 19% with obesity. And what we found was that the rate of biopsy-proven acute rejection was higher in our bypass patients because their tacrolimus levels were actually, their trough levels were low. So the conclusion for our transplant team was that they had to perform more frequent levels in these cases to try to avoid acute rejection episodes. Our overall mortality, graft survival, and everything was similar between the two groups, but they did have more episodes of acute rejection post-op. And what to do with PD patients? I get asked this question all the time. We published it a few years ago, and we actually don't interrupt our peritoneal dialysis in patients that are doing surgery. I've done sleeves, bands, and bypasses with it. We use half the volume for the first couple of days post-operatively. They don't leak like crazy, and as a matter of fact, they do so well that I've joked a couple of times that I was going to put PD catheters in everybody because they feel less pain. I think it washes out all the inflammatory humors, and the patients feel significantly better than even the regular patients. So conclusions, I think, as others have said, we need to go ahead and do this in centers that have access to transplant teams to help you out for the post-operative issues, but it can be done safely and definitely makes a difference in getting them on the transplant list. Thank you very much.
Thank you. I think we will go to the next speaker and then have a discussion. Makes sense?
Thank you.
Okay. Please, I invite to the podium Gianluca Rompianesi. He's from my team. He will give a talk on robotic kidney transplant in obesity level first and second recipient.
Hello, good morning, and thank you for the opportunity of being here. In the meantime, my only disclaimer that I'm not a bariatric surgeon, I'm a transplant surgeon, so bear with me with that, please. So, Thankfully, kidney transplantation, being the treatment of choice for end-stage renal disease, has moved past the first survival results. Now, survival are exceeding 90 to 95% in 1 year, and kidney transplantation are ubiquitously doing significantly better than hemodialysis patient. So the focus has moved to long-term survival, morbidity, of course, quality of life, and the access to transplantation, to be fair and for every possible patient. As highlighted earlier on, the previous speakers are making my life way easier. Obesity impacts significantly access to transplantation before the waiting list, during the waiting list, during the transplant, and in the post-transplant period as well. And is the third leading cause of suspension from the waiting list. So patient losing access temporarily or permanently to the kidney transplant. All data published already in the literature, and these are data from Federico II here in Naples Transplant Center, where we can see that in our patients on the waiting list, 41 out of 150 approximately are suspended from the list, and the BMI for the suspended patient is significantly higher of the patient active on the waiting list. After transplant for the recipients, we can see that patients experiencing delayed graft function, so having the need for dialysis after transplantation, have a significantly higher BMI. Same thing for the incidence of acute rejection, so is higher the average BMI of patient experiencing rejection after the transplant. The length of stay is longer in this patient due to surgical and non-surgical complications. Of course, even if obese patients are more complicated, carry more risk, both in the kidney function, kidney survival, and outcomes, this is still better at all levels than dialysis. What do the guidelines say? That extreme caution should be taken when the BMI approaches 40 or goes above 40. These are high risk patients that individually should be managed at transplant center according to the policies, but it's known that the outcomes are inferior and something should be done to optimize the results in this group of patients. Since the 50s, when the first kidney transplant was successfully performed, has been moved gradually, like other transplant, towards the minimally invasive approach, starting with first anecdotal cases in the early 2000s, and the first complete robotic and laparoscopic cases have been performed in 2009. The laparoscopic wave has not progressed very much, unlike the robotic one. So it's about a decade that robotic attempts have been tried to fully perform a kidney implant. Of course, it needs to reproduce the steps that are in the open procedure. In the open procedure, we perform an extraperitoneal access in the iliac fossa in order to have access to the external iliac vessels, artery and vein. The vein anastomosis is the first one to be performed, then the arterial one. Iliac fossa is a good place because the kidney lies quite close to the bladder, so we can keep a short and well-vascularized ureter in order to obtain the ureteric drainage as well. So we attempt not to touch the peritoneum, not to come anywhere close to the intra-abdominal organs. And back. Okay. What happens in the robotic approach? So the vessels are the same, the steps to be performed are the same. The problem is the approach. It's quite difficult, if not impossible, to perform an extraperitoneal procedure. As you can see, you go from intraperitoneal to extraperitoneal in order to have access to the iliac vessels. Then an extra step is this one. You need to mobilize the bladder, have a closer and accessible bladder for the ureteric anastomosis, and this step needs to be performed early in the surgery. Then you can see is a temporary clamp of the vein first, and then the artery. In this phase, in the robotic surgery, unlike the open one, you see the kidneys lying inside the abdomen, so it's rewarming a bit, which is a bit of an issue. We do not want warm ischemia time because this is damaging the organ even more. After the venous testing of the anastomosis, the clamps are moved onto the artery and the anterior anastomosis is performed. One of the difficult steps and limitation of this technique are severe atherosclerosis. You can imagine that using like bulldog clamps and not the proper clamps, and not being able even just to feel with your hand how the vessels are and when to place the vessels is a critical bit. This is even worse in grafts with multiple vessels, which is fairly common in case of kidneys. We very often have 2 arteries on the same patch, 2 arteries on different patch, 3 arteries or more. So after a perfusion, the kidney, which is now not in the final position because we will try to make it extraperitoneal, needs to be rotated. This is not a critical step, so you can't really see and program which will be the final lie of the kidney, which is important depending on the length of the vessel, because you don't want them to be kinked too long or under too much tension. So try to separate the kidney graft from the peritoneal space with the peritoneal flap. And then the ureteric anastomosis. So promising results, these are all on super selected cohorts of patients. Of course, only a few hundred cases performed around the world, mainly in the States and in Spain. So good outcome results, feels safe, low complication rate, but the main focus is on obese patients. So the Chicago group has tried to see if a robotic approach can give access to obese patients, severely obese patients, that would not have the chance of a kidney transplant otherwise. And it looks like, you can see, the average BMI is over 42 in this case series. So acceptable rate of complication, less wound complication, less wound infection, higher creatinine discharge, but not translating into a worse graft outcome. And of course, increased costs because of the robotic platform. Fascinating scenario to perform at the same time simultaneously robotic sleeve gastrectomy and the kidney implant. Quite a few readmissions, mainly due to nausea and vomiting, probably complication following bariatric surgery rather than the transplant itself. Good results in terms of weight loss and change of BMI. So this approach has pros and cons. Of course, the advantages are all the ones of the robotic approach, so easy, comfy for the surgeon, magnification. On the other side, you need to consider slightly longer operative times, especially in the very beginning of the journey, longer cold ischemia time and this warm ischemia time mentioned earlier on, and the difficult positioning of the kidney, and of course higher costs. The current guidelines mention robotic implants, so KDIGO guidelines are very nephrological heavy, so they're a bit more behind in terms of surgical techniques. They accept that a robotic implant exists, but shows benefits only in a super selected group of obese patients, and of course needs to be performed only in expert centers. Urological guidelines, so they acknowledge advantages of the robotic implant, especially in terms of morbidity, incision length, saline fossile complication. Downsides are, of course, some of the ones that were mentioned, so patient with severe atherosclerosis, redo transplant, and multiple vessels. And they set a learning curve at around 35 cases to master the procedure. So now, as we say that evidence is too premature to recommend like robotic kidney transplant for all patients. So in conclusion, evidence level 1 is still lacking, but promising results have showed a potential road for the robotic implant in selected patients with obesity, and is not only not inferior to the open approach, but can give some advantage in these patients. Limitations are surgical of the patient, cost effectiveness, and the fact that we need to consider 2 different populations, living donors, where is elective procedure, and deceased donor where you never know when it's going to happen, daytime, nighttime, weekends, Christmas Day. So do you have the robot available 24/7 to perform these cases? Does this clash with your elective activity? Do you need to cancel other cases? So all these costs needs to be taken in consideration. Fascinating, the association with the sleeve gastrectomy. Important to be considered the timing, because if you perform it at the robotic approach to implant the kidney, of course you are bypassing some of the BMI issues, but you're not solving it. You are left with a high BMI obese patient with all the complications that may relate to that, and are a patient that are taking often high doses of steroids, so likely to increase their weight on their own apart from their previous obesity. Thank you.
Thank you so much. So time for questions.
Thank you very much. Francesco Papadia from Genova. I have a question. is there any data on late graft failure due to enteric hyperoxaluria, especially after gastric bypass, because it can be an issue?
What's the question?
The question is, gastric bypass has a 6-fold increase of hyperoxaluria compared to sleeve. So is there an issue about hyperoxaluric nephropathy and leading to graft loss if transplantations are submitted to gastric bypass versus sleeve?
Esther, you want to ask? I think it's probably more for you to answer from there. Thank you.
Yeah, there is a concern. I didn't see any good data on it, but it was in multiple papers. There was a concern about the risk of a potential graft loss in the long term. I think probably the numbers are just too short and people aren't following enough of them far enough out to know if it really plays itself out.
Ian Michelle from Melbourne. Can I give an alternative answer to that? Because as a transplant surgeon, I've talked about this with my nephrologists, and it's a bit more complicated. That when you have a patient in renal failure with a transplant and a solitary kidney, there's greater renal plasma flow, and that actually protects against the oxalosis. So it's perhaps not an important problem. Thanks.
Okay.
Thank you.
So, we go ahead. I invite to the podium the next speaker, Rana Pulat. She's here?
Yes.
Okay,
Yes.
he is there. So he will give a talk on liver transplant and nuance with bariatric surgery. Please.
Thank you very much to the chair and the panel. These are my disclosures. Should have no bearing. I'm also a transplant-trained surgeon who switched to bariatric surgery for lifestyle. That's my other disclosure. So as Professor Gertz mentioned, we should all be sticking to not fatty liver disease or alcoholic liver. This is just the steatotic liver disease spectrum. I'm not going to belabor, but there's definitely a difference in steatotic, metabolically active fatty liver disease. So you have to look at the pathology, and if it shows hepatocyte ballooning and degeneration with inflammation, you're looking at NASH. It's the fastest growing indication for liver transplant and will become the most common cause for liver transplant in the next few years. The scope of the problem is huge. As you can see, it covers the entire area. In the 5% of the entire US population has MASH, and MAFLD is present in about 40% of America and Southeast Asia. And the progression of MASH and MAFLD is from just having overwhelming amount of free fatty acids, which then overwhelms the capacity of the liver to package it into VLDL, and then you have oxidative stress. These are influenced by genetic polymorphisms, as well as environmental factors and dietary factors. What is the need for metabolic and bariatric surgery? There's a high prevalence of obesity in the liver transplant cohort. BMI is greater than 40 is the cutoff in most programs. Liver transplant is technically very challenging in obese patients. The immunosuppressive medications themselves are obesogenic. Immunosuppressive medications are diabetogenic, and diabetes mellitus is an independent factor for graft loss. Obese liver transplant patients are high risk for metabolic and CVA events, and recurrence of NASH or MASH after transplant is 30 to 100% if you look at the case report. Choice of procedure between sleeve and the bypass and SADDS. You want to do a sleeve because it's technically less challenging. It's easiest to maintain immunosuppression levels. However, in a short BPLM gastric bypass, you should not have trouble maintaining immunosuppression very well. The reason you don't do, in liver patients, you don't do a gastric bypass is because the access to the biliary tree is lost if you do a gastric bypass. So that's why the preference for sleeve is there. What are the ways in which you assess the patient before liver transplant? you can do the child score, and you know the mortality rates of A is 10%, B is 30%, C is 80%. However, ascites and encephalopathy are subjective. So a better use would be a MELD. For a score less than 20, there's a 1% increase in mortality for every point that goes up. For a score about 20, there's a 2% increase in mortality for every point that goes up. MELD about 8 is kind of prohibitive risk. Why is it so difficult? Portal hypertension causes splenomegaly and reduced platelets. Ascites can interfere in wound healing, however, not a great issue because most of the surgery is now minimally invasive. It can cause pulmonary atelectasis, cause varices and shunts, and there's a bunch of peri-op fluid shifts, and the risks of TIPS should be weighed into pushing some of these patients into hepatic encephalopathy. What is the disadvantage of doing metabolic and bariatric surgery before liver transplant? There's a higher risk of bleeding. It can cause progression to decompensated cirrhosis or liver failure. If the patient leaks, you may prevent the patient from qualifying for liver transplant. If the patient leaks, it may make a future liver transplant difficult due to adhesions. The advantages of doing metabolic and bariatric surgery before liver transplant: it makes liver transplant less challenging due to body habitus change. It may cause the patient to be delisted due to improvement in liver disease, and it may actually improve the chances of getting listed because of weight loss. So this has been looked at in metabolic surgery before liver transplant in well-compensated cirrhotic patients. The overall complication rate is higher, 13.6% versus 6.3%. The hospital length is higher in the cirrhotic group. There's a significantly higher 90-day mortality in the cirrhotic group compared to the non-cirrhotics. However, at 12 months, the mortality rate is equivalent, and the total weight loss between the two groups are equivalent at 12 months. What about during liver transplant? What are the advantages of doing it at the time of liver transplant? It's one operation, one hospital stay, so more economical from the hospital standpoint. There's resolution of portal hypertension once you put the liver in. There's no adhesions. There's no barriers to bariatric surgery because you're already open. And the graft has best chance of avoiding de novo steatosis. What are the disadvantages? Complications from bariatric surgery can have severe consequences. A leak could become life-threatening, infection, bleeding. Immunosuppression has to be modified based on your complication, which may then have adverse effects on graft survival. This is the Heimbach group that, from Mayo Clinic that published the first series in 2013. They looked at 7 patients who underwent a simultaneous sleeve liver transplant compared with 37 patients who just had medical weight loss. All of them had a BMI greater than 35. You can see that there's a substantial difference in the two groups. The BMI was 29 in the combined group, and there's no diabetes mellitus, no steatosis, no deaths, no graft loss, compared to 3 deaths and 3 graft loss if you just did it on a high obese patient. And 1 sleeve leak was present in the combined liver transplant, and 1 patient had a failure to thrive, which they had to put a J tube in. And you can see a very good BMI trend for the combined procedure. What about an interval stage procedure? So this is another approach that can be done if you're doing a liver transplant and you're taking the patient back to the ICU with an open abdomen, and you're packing the abdomen and bringing back the patient. Once the coagulopathy is settled, then you do the liver transplant. And this group looked at that. There was 14 cases, 2-stage liver transplant with sleeve gastrectomy, and 28 patients which had a 2-stage with no sleeve gastrectomy. And you can see there's a substantial difference in weight loss, and the graft survival was also improved. And there was no intervention due to the sleeve gastrectomy, and it may be a feasible option of performing sleeve gastrectomy in high-risk patients. And this is the pathology change if you do a Roux-en-Y gastric bypass in steatohepatitis, and you can see the pretty good reversal. And the last group that we look at is the safety and efficacy of sleeve gastrectomy. following liver transplantation. Lin and group were the first to look at. They showed that there were comparable weight loss with non-liver transplant recipients. They had one major complication, and that was related to a mesh repair of a hernia at the same time, and another patient required conversion to a gastric bypass. This was again looked at by another group which looked at a larger cohort, and the complication rate was very similar. The non-liver transplant group had a shorter hospital stay, and resolution of obesity-related comorbidities was similar between two groups. The major complications in the sleeve gastrectomy group was 25%, including need for sleeve dilation. All major complications were related to poor oral intake, no liver complications, no alteration in immunosuppression. So while we are looking at surgery, we also need to look at the medical world. The most important study that was done was the LEAN study, or the liraglutide efficacy and action in NASH study, which showed NASH resolution in 39% versus 9% placebo group, as well as tirzepatide shows an 8% reduction in liver fat. This is again another placebo-controlled trial of subcutaneous semaglutide in NASH. It showed improvement in NASH with 40% at 0.1 mg and then 59% at 0.4 mg. Improvement of fibrosis, though, was pretty limited, 43% in 0.4 mg and 33% in placebo. So conclusions, metabolic and bariatric surgery in the context of liver transplant is very important tool to help patients qualify for liver transplant and to prevent MAFLD in transplant patients. Sleeve gastrectomy seems to be the safest. The medical therapy with GLP-1 and GIP co-agonists may be useful as a standalone strategy in high-risk surgical patients or as a combination and rescue therapy along with metabolic and bariatric surgery. So you have to remember that the GLP-1s are excreted through the kidney, so they're pretty safe in liver patients. So this ends my talk. I've kept my time. I've got 1 minute. Thank you very much.
Questions from the floor? So, please.
Oh, go ahead.
Marina?
No. I just want to make a comment that, as Dr. Geertz pointed out, this is changed now. We're not calling it NAFLD or NASH, and I know you made the verbal correction, but of course all the old studies say NAFLD, but it's now metabolically active fatty liver disease. So.
Thank you. So the question whether before, during, or after transplant, making some maybe sleeve gastrectomy is still...
Yes. So I
answer it. I mean...
Yeah. Pardon me?
We don't know exactly which kind of patient may benefit before, during, or after.
I think during requires a lot of coordination. Now that the livers can be pumped and be done in an elective session, maybe it'll catch on during, but in our practice, we do both before and after, before in very carefully selected patients. After, the adhesion level is not that great because of the immunosuppression and the corticosteroids. It's not very different from, you can very safely go and do it after. But you definitely do not want to put the patient in a catabolic phase immediately after liver transplant. I think that's a bad idea.
Okay.
Thank you.
Thank you.
All right, thank you very much. It's my pleasure to introduce the final presenter of our session today. It's Matthias Sepulveda from Chile, and he's talking about pancreas and small intestine transplantation and its pitfalls. Looking forward to your talk. Thank you.
Thank you very much. Okay, we're good. Thank you very much for the invitation. I'm sorry. Okay, we're good. Yes. So my disclosures, I'm going to talk about pancreas and small intestine. This is my disclosure. I'm not a transplant surgeon, but I've done bariatric surgery and donor and recipients of liver transplant. So we have talked all the morning about the benefits of weight loss in the candidate for transplants. I'm not going to go further on this. And but therefore, bariatric surgery presents an attractive option for weight loss due to that the medical treatment is not as well as bariatric surgery for this. So, going into the topic, I'm going to talk about pancreas transplantation first. And we know the indications for pancreas transplantation are type 1 diabetes. This is the formal one and the oldest one that cannot be controlled with standard treatment, hypoglycemia, insulin reactions, poor blood sugar control, and severe kidney damage. As we're going to see, most of the transplantation in these patients are simultaneous with kidney. And now, type 2 diabetes associated with poor glycemic control and or hypoglycemia unawareness. This is a new indication for pancreas transplantation, and we're going to talk about that also, because the difference between type 1 and type 2 is in type 1 patients, they are thinner, they are younger patients, and in type 2 diabetes, they are older patients, and also with a high obesity prevalence. So until now, around 12 or 15 of pancreas transplants worldwide were performed in patients with type 2 diabetes. So there are various methods of pancreatic transplantations. First, pancreatic transplantation alone, PTA, or simultaneous pancreas and kidney transplant, or pancreas after kidney transplant. These are patients that couldn't wait for the pancreas and kidney transplant, so they had the kidney transplant first and waited for the pancreas after the kidney transplant. So what about the BMI? The UNOS guidelines said that the BMI in this kind of patients should be less than 28 and could be increased or decreased by 2 depending on the size and composition of the wait list. So bariatric surgery increases eligibility for a transplant. We know that, we heard about that all the morning, and especially in kidney transplant, but there are few papers talking about pancreatic transplantation. Actually, in our guidelines, and IFSO guidelines, and ASMBS guidelines, there's nothing about pancreas. There's nothing specific about pancreas. So the literature is very scarce in this topic. I'm going to show you 3 papers, case reports of bariatric surgery before pancreatic transplantation. And this is the first, this is 2012. This group retrospectively reviewed patients that had surgery prior to pancreatic transplantation. These 4 patients, of 352 pancreatic transplant, only 4 cases of pancreas alone, pancreas transplantation alone for type 1 diabetes, had prior bariatric surgery. They have, you can see that the BMI of the patients are very high. And they have 1 complication after the transplant, 1 reoperation for bowel obstruction. But we have to point out that bariatric surgery here was with no intention to prepare the patients for transplant. The patients had the, had the bariatric surgery for obesity, and then they happened to have the transplantation of the pancreas. And this is another paper, case report. Thank you, Marina. Of Dr. Marco Buta here in the board, yes. And they presented the sleeve gastrectomy for before with the intention to lower the BMI of the patients in order to do the simultaneous pancreas and kidney transplantation in severely obese patients. Of 132 transplantations, all for type 1 diabetes, 3 patients underwent laparoscopic sleeve gastrectomy for morbid obesity. These are the BMI, and they were successful in lowering the BMI and make these patients ready for pancreatic and kidney transplantation. And not only the BMI, and they lower the weight, but they lower also the A1C and improvement of the kidney function previous to the transplant. So these patients went well. They had 2 complications, no mortality. But this is normal in this kind of surgeries. And finally, another case report I found. This is from Brazil. And they did an experimental previous surgery. They did bypass gastric surgery in patients, but with mild obesity, only below 35, with type 2 diabetes. And they did a gastric bypass with good results. Actually, 3 of these patients at 1 month went off insulin, and the other 2 reduced up to 70% the insulin usage. 1 patient, unfortunately, died of pyelonephritis. So this is about pancreatic transplantation. What about small bowel transplantation? Well, whereas pancreatic transplantation is rare in bariatric surgery, intestinal transplantation is more documented. And the main indication is failure of parenteral nutrition in these patients. So bariatric surgery, how it's related to intestinal transplantation, I think is the opposite to pancreatic transplantation. Meanwhile, in pancreatic, we do surgery to save these patients and make them suitable to transplantation. In intestinal transplantation, we see that bariatric surgery can lead to intestinal failure and finally intestinal transplantation. In this experience, of 25 patients with intestinal failure after bariatric surgery, 92% of them were Roux-en-Y gastric bypass, and the major cause was, of course, internal hernia, 72%. And 5 of these patients did transplantation. Actually, they have an algorithm to treat this patient, even intestinal rehabilitation before going to intestinal transplantation. But what about the causes? The causes in this 20 years of experience in Cleveland Clinic, published in 2015, we can see that in red are the causes that lead to intestinal transplantation, like strangulation, vascular occlusion. In green, the complication of the bariatric surgery, as leaks, for example. And in blue, the medical reasons to intestinal failure. So of 116 patients that did surgical treatment for these complications, 20% of them were patients that had transplantation. Actually, these are all the surgeries that they had to do to avoid intestinal transplantation, reconstructions, reversals, and all type of modification of the digestive transit. And of course, intestinal transplantation. So finally, in conclusion, overweight and obesity are still factors that negatively impact patient and graft survival after pancreas transplantation. Bariatric surgery prior to pancreas transplantation may be of increasing relevance for type 2 diabetes patients and warrants further study. This means that significant number of patients on the waiting list for pancreas transplant would be potential candidates for undergoing metabolic procedure thanks to type 2 diabetes. So as these patients are higher rates of obesity, it's fundamental to have metabolic surgery before. And intestinal failure after bariatric surgery is an uncommon but severe complication, especially in Roux-en-Y gastric bypass. Internal hernia, mesenteric thrombosis, and complication for the bariatric surgery are the main causes. And transplantation is a risky treatment in patients with intestinal failure. So finally, I want to invite you all to Santiago in Chile, 2025, we're going to have a World Congress there. Thank you very much.
Well, thank you very much for, finding all these cases in the literature. There are not many. Are there any questions from the audience? Yes, please.
Excellent talk. About a year ago, I reviewed all this literature, and I saw the same trends that the Mayo Clinic showed, which was many of the early small bowel losses were more adhesive disease back when surgery was open, and now we're seeing small catastrophic loss from internal hernias. What do you think is going to happen with sleeves and portal vein thrombosis?
Well, fortunately, portal vein thrombosis is not of high incidence. And I have seen, well, in Chile we have a high incidence of it. Actually, we have lots of publication from there. I don't know why in the first half of the last decades, but I haven't seen in the experience a loss of all the small bowel with this complication in my country and in this kind of review. But here they had this problem. I think it's something that should be studied. Could be a complication leading to extensive failure also and transplantation.
And just, I don't know how many of you all have experience with this, but I have a new interventional radiologist. I had a young guy who was the perfect patient, did everything, couldn't figure out why. He had a massive portal vein thrombosis extending to the liver, and this would have crippled him for the rest of his life, right, potentially. And this IR guy just went in there and sucked the clot and did it, and this kid is perfect. So it's always important to at least consider that, to have them go in there and retrieve the clot. I didn't have to do a thrombectomy. There's a lot in the literature about doing it surgically, so this is just something to be aware that your IR guys could maybe, or gals, might be able to do that. All right, so I'm going to end this session. We are a little over time. Thank you to my co-chair. Thank you to our moderator. And to all of our speakers, thank you. Thanks for all the engagement. Oh,
there was one more.
Did you have a question?
Yes.
Oh.
About pancreas transplantation, I would like to know how many patients in list of pancreas transplantation alone with type 2 diabetes don't underwent a pancreas transplantation after weight loss. Thank you.
What was the question? How many had? Didn't. I don't have the answer. I'm sorry. No, I don't have the answer. I only have this 12 cases of pancreas transplantation after bariatric surgery. I don't know how many didn't. Marco, do you have an answer from the university? Okay.
Well, thank you very much. Thank you.
Can I thank you so much for this session? We've gone from small case reports of bariatric surgery and transplantation now to small series and some registry data. It's an amazing future. A diabetic going on to dialysis has a 50% chance of living 5 years. If they have a renal transplant, they've got a 90% chance of 5 years. They've got a 2% chance of dying in having their transplant. These sort of complications are huge, and here we are, bariatric surgeons, talking about sleeve gastrectomy mortality of 1 in 2,000. It's an entirely different perspective. This is such an important session. Thank you so much.
Thank you. Good, so. Yes.